another edition of Expressions with the New Indian Express. I have with me Professor Vikram Patel of the Harvard Medical School, one of the world's foremost mental health experts, and someone who's actually done work right down to the grassroots. He's founded a not-for-profit called Sangat, which has been working in Goa, which is a really good partnership, as he was just telling me, with the Madhya Pradesh government as well. And he's been really important in bringing awareness of the mental health problem in India, which has been quite incredible in the way it has looked at patients. And I think that's just one of the many things that he's done to bring awareness of this crisis, and especially during COVID, where we've talked about the pandemic, but the other silent epidemic really has been the mental health crisis. So thank you so much for joining us from Boston, cold Boston, I imagine, Professor Patel. Thank you so much. And really, let's talk about the silent epidemic, while this other epidemic was raging.
I think what you said about the act is extremely important. I completely agree with you. I think it is the first, entitlements-based legislation for healthcare in India, which is
Yes.
quite interesting when you think about it. In a country in which our political parties are often very polarized, that mental health should be the one subject that had bipartisan, multi-partisan agreement, and where all sides got together. And it's interesting, it's the same in the US. Where there may be enormous polarization on every single issue, but not on mental health. So it's important to first acknowledge that we're a unique point in history where all political parties, regardless of what the persuasion is ideologically, all agree that mental health is a very important subject. And in fact, there's even more agreement on mental health and physical health when it comes to the role of the state.
Yeah.
I think that is another very interesting thing in the US as well, where there are huge divisions about the role of government when it comes to healthcare. There is much less disagreement when it comes to mental health care. So I think this is a really important starting point for our conversation. And we can talk about how we got to this incredible point, but it is important to remember that there is tremendous political will nationally, globally, at all levels now, from the UN Secretary General to government leaders on mental health. The question now is, what do we need to see action on the ground?
Yes. And doctor, the thing about the Mental Health Act as well, I just want to come back to it, is that it puts the patient or the affected person bang in the center of it. It doesn't treat him like a criminal. It doesn't stigmatize him. It actually gives him or her far more rights than he or she has ever had. If we look at some of the mental health institutions that we're all familiar with, they're really like Dickensian, out of Dickensian novels. So I think that, of course, is the next step to reform them. And you have also talked about that at length. But can we also talk about this whole destigmatization of mental health illnesses?
So I think these two issues are connected.
Yeah.
A rights-based approach to mental health and destigmatization are actually two sides of the same coin. And let me explain why. We often think of stigma to do with mental health problems as emerging because people are unaware
Yeah.
about the nature of mental health problems. They're not empathetic, they're not compassionate, or they have some kind of old-fashioned ideas to do with spiritual and supernatural causation. I don't think that is actually the main reason for stigma, because stigma occurs in every society around the world. And it is not the case that every single culture around the world has exactly the same ideas about mental illness. That's impossible. The one thing that every society shares around the world is the way that the medical system has dealt with people with mental illness over the centuries. Whatever that medical system was, 200 years ago, it would have been some other system. Over the last 100 years, the dominant system has been biomedicine and psychiatry as a discipline of biomedicine. And so let us for a moment think about what biomedicine has done for people with serious mental illness. It is the only health condition in which you're likely to be imprisoned against your wishes.
Yes.
Nobody with breast cancer will be carted off by the police to a magistrate's court. But if
Right.
you have a mental illness, you will be
Yes.
in certain circumstances. No other condition involves you being locked away in what is called a hospital, far away from the city, far away from everyone else, and where no one else can enter that building. What kind of hospital is that? So if you think of that, and the third is the interventions are entirely hospital based, nothing in the community,
Yeah.
and they're totally focused on sedative medication. This has been the dominant paradigm of mental health care universally for a century.
Yes.
So, in effect, there is enormous fear. There is enormous fear about the label of mental illness because you will be stripped of your citizenship rights. You'll be stripped of your right to marry. You'll be stripped of your right to inherit. In some countries, you were stripped of your right to vote. You cease to be an individual.
Yeah.
Then you are risking the chances of being locked away by the police in a prison or in a prison like hospital and being doped up to your eyeballs with no recourse to get out.
Right.
Why would there not be stigma? I
Yeah.
mean, think about it. It's an absurdity. So, where we really need to address stigma is through the way we address mental health problems from a community focused, rights based perspective, in which the rights of a person to choose the care they receive in a place of their choice must be paramount.
Right. And let's talk about how we've come to this point, Dr. Patel, and how COVID has it exacerbated this situation? Has it made people understand, or has it made people understand less?
I think certainly COVID has enormously benefited the situation by creating an open conversation about mental health. I mean, let's be honest, the number of the amount of interest there is on mental health. I mean, from my own personal experience, a number of webinars I've done for companies, for newspapers, and so on mental health. In this last 6 months, I probably have done more than I have done in the last 5 years.
Right.
Um, and this is entirely a reflection of the enormous interest in mental health, which of course comes from the personal experiences that people have around the country and the world. The problem is this. The problem is that the conversations are very much around a kind of reaction of one's mind to a very extreme, extraordinary
Yeah.
situation rather than mental illness.
Yeah.
And so, while we should acknowledge and welcome the conversations about the stressful circumstances we all face, we should not medicalize it. I don't think we should ever medicalize what is happening in our minds in a reaction to the pandemic. But equally, we should recognize that this is not the same subject
Hmm.
as the issues around access to quality care, a respectful rights based care for people with mental illnesses, because only a minority of the people who are feeling stressed actually have a mental illness.
Yeah.
Because for most people, these stressful experiences are normative. They're part of the normative human mind's response to a very extraordinary situation.
Right. That's interesting. And doctor, here is of course also where you talk about the kind of care and the democratization of care. And you've often talked of the fact that even if we don't have enough psychiatrists as we go on and on, talking about the lack of psychiatrists we have in India compared to the global norm, you've often talked about the democratization of, healthcare. Let's talk a little about that and the approach that you have.
So let me first say, Kaveri, and let me give credit to the approach that I have been following, to the fact that this is an approach that many people before me have actually followed. And that's the idea that healthcare is a plural
Yeah.
delivery system where multiple different kinds of providers need to work in a coordinated way. No one size fits all. And perhaps the greatest champion of this has been the community health worker movement in India, which is, decades old.
Right.
In fact, India has the largest community health worker program in the world. And one has to give credit to the incredible innovations that NGOs initiated in this country, the support they got from state governments around the country, from initially governments like Chhattisgarh and Jharkhand. And now, of course, it is a federal national program. So we must acknowledge that community health workers have been playing profoundly important roles. Much of the improvement we have seen in India in reducing maternal and infant mortality is at the hands of the community health worker innovation. Okay,
That's
it's
the
not about
Asha. The
the
Asha.
ashas, the ANMs, the Anganwadi workers. There's a range of different. Now we have the Health and Wellness Center with a community health officer. So there's various garbs they wear and under different programs, different ministries. But the essence is the same. And I think we should acknowledge that it wasn't the obstetrician or gynecologist who brought maternal and infant mortality down without the active role of the ASHA mobilizing women to come to hospital to have their babies there. So, I think it's a team. It's a team that we have to consider. So I've simply taken this idea, which is very old in India, and applied it to mental health. That's all I've done.
Hmm.
There's nothing radical about it. The only radical piece, if there is any, is the fact that historically mental health care was thought of as being so complicated
Yes.
that only somebody with a very high degree of training could deliver it. We've been able to demonstrate in India and as well in many other countries around the world now that actually with appropriate training and supervision, community-based workers can also do this in the same way that they can also help mothers with newborn infections.
Right. So again, you've helped to destigmatize it, and also, as you were just saying a minute ago, demedicalize it. Is that important to separate the mental health care from this sedative aspect of it?
So let me be clear. I think what I do is medical in the sense that we are dealing with clinically significant mental health conditions. Okay,
Right.
so let me be very clear about that.
Right.
When you use the word demedicalize, where I will agree with you is that if that implies that all people with mental health conditions need to see an MD, that I disagree with.
Right.
So I would say democratize is a better word. That we have to tailor interventions for people according to their need and according to their resource availability. So, for example, if I lived in a remote hamlet
Yeah.
somewhere in India where there was no psychiatrist or psychologist available for 100 kilometers, but there was an ASHA who was available in the next house,
Hmm.
that should be my first point of
Right.
call. That is what community-based primary care should look like rather than asking you to trek a whole day to see a doctor somewhere far away. Let me also say one more thing. Most mental health professionals are not equipped even to actually deal with community-based issues because they have never actually worked in the community. They have mostly worked in hospital settings. So they're very well skilled with dealing with complex, severe, acute kinds of presentations. But the more common mood, anxiety, and trauma related conditions that are very intertwined with people's social lives
Right.
and therefore their community lives. I'm a psychiatrist. I never stepped out of my hospital until I chose after my training to dedicate my life to community health. But otherwise, during my training, I never stepped out of the hospital. So
Right.
there's nothing that really prepares me in the
Right.
way that an ASHA or an A&M or an Anganwadi worker or a community health officer actually has in terms of first-hand boots on the ground experience of real communities.
Has the new architecture for medical education in India, has it taken note of this?
I believe, I haven't done a deep study on this, Kaveri, and I don't want to comment, but my understanding is there is certainly a much stronger appreciation that medical education in India, which for far too long has been a clone of
Yeah.
the education in Britain, basically transplanted to India. Like so many things,
Hmm.
I think there is a genuine effort to make it more relevant to our context. I mean, it is so incredible when I think of my medical education. I was trained better to work in a hospital in the US or in a private hospital in India than I was to work in a primary health center in my own country.
Right.
And I think that has to change. And I believe that the proposed new curriculum is strengthening much more the roots of the curriculum with India's contextual realities.
Right. I think that would be quite heartening. But Dr. Patel, I also want to focus again on pandemic and the kinds of cases that we've seen, from the really well known to things that have not come to the fore. For instance, the Sushant Singh Rajput suicide brought so much attention, good and bad, to the conversation. Uh, what has your understanding been now, 8 months down the line? Are we aware of the contours of what is the size of this mental health crisis in India and globally?
So let me just say first about the Sushant Singh Rajput suicide. It has nothing to do with mental health. His
Right.
tragic death was related to his poor mental health.
Yeah.
But the media attention around this, as you know very well, is a perverse, almost vulgar, obscene way in which certain sections of the media have violated his family's rights to privacy as well as the rights of his friends and partners. And I think that is enough to be said about that. I don't want to say anything more. But
Right.
let's be clear: there was no compassion. There was nothing about mental health. It
No
was
empathy that was
cruel. No,
shown.
none at all, none at all. And whoever is behind all of those, that intrusion into their lives, is guilty of violation of those basic rights. But let's leave that aside. They have to sleep at night themselves, and they have to deal with their own conscience. But let's turn to your question about the 8 months.
Yes.
So we don't actually have any data, a really good data from India. So I can't comment on India, but I'll be surprised if the situation in India is any different from the US, because across the world, one thing that the pandemic has done is created very similar risk factors for mental health problems. For example, the economic uncertainty.
Yeah.
For example, for young people, the uncertainty about jobs, about education, and so on. So there's a lot of parallels. And in the US, there is actually data coming from the CDC showing a dramatic increase in the prevalence rates of mood, anxiety, and trauma-related mental health conditions. Dramatic meaning almost twofold, particularly in young adults, which is a high-risk group for the emergence of mental health problems, but also it's a group that has suffered the most, not because of the virus, because curiously the virus is almost harmless in young people,
Yeah.
but the consequences of
Yeah.
controlling the virus has affected young people the most. So you see dramatic increases, plus the initial signals of an uptick in suicide mortality. So I think it is really important for us not to wait for those data to come from India.
Yeah.
There's no need for us to wait to see whether there is a problem that's increasing. We already had a huge problem before the pandemic. Now is the time to act, to make sure that the amazing science we have in India on how we can deliver mental health care, regardless of how many mental health professionals we have, that is actually adequately financed and delivered across the country.
How do we do that, Doctor? Do we do that at the state level? Do we do that at the central level? Is there one model that you can suggest? Are there two or three basic things that need to be done?
Yeah, well, actually, state is health is a state subject, so it has
Yeah.
to be done at state level.
Has to be
But
done.
but obviously the center plays a role in the amount of money it gives. I mean, that is the main thing. But ultimately, it's a state level, and many states are doing some pretty amazing things, like Kerala. I heard recently a health secretary from Chhattisgarh describing what looked like an almost a model mental health program in that state. So I think there are many states that are doing various things at the central level. We have the helplines and so on. So one has to give credit to all these efforts. But I think on a massive scale, what we really need is a system to train and create quality in the delivery of care for India's army of frontline workers.
Yeah.
When each state does their own thing, imagine we're talking of a million plus frontline workers. How can you train a million frontline
Yeah.
workers in this kind of format? So what Sangat is doing in partnership with the Madhya Pradesh government is actually piloting a digital platform through which Ashas can download an app and learn evidence-based treatments through very systematically designed online curricula, which can be downloaded. So you don't even need the internet, actually.
Right.
And then now we're building we're looking for funding, and we're almost certainly going to get it. We're building the supervision platform so that essentially, think about this: an Asha can essentially take a phone, she can essentially download the app, she can learn foundational skills for mental health care, she can learn the brief depression treatment that we Sangat developed and evaluated. She can then learn new treatments for mental health promotion and so on, all on her phone, in the evenings, in the daytime, on the weekends, at her own leisure. She can then complete the exam on her phone,
Wow.
and then she can start seeing patients supported by tools on her phone, as well as supervision that is done through audio, basically this sort of webinar format. Now, this would mean that once you have, let's say, a Hindi curriculum ready, you can train every Hindi speaking Asha within 3 months in the whole country.
Yeah.
So that is the kind of goal we're going towards, like a massive scale up. And we're lucky that we already have some support from the Tata Trust to begin to take our work in Madhya Pradesh, which was originally research. Now it's being translated into these tools that are scale up. We're looking for funding from some other partners in India through CSR. But what's interesting, Kaveri, and this would really interest you and your listeners, is this: that we're doing exactly the same thing in the US.
Oh,
And so we're taking an innovation that came from
wow.
India, and we're transplanting it to the US. And in India and the US, we're working simultaneously to build these digital platforms for training frontline workers and with the same treatments as well.
Right.
In the US, this is being done by Harvard Medical School in partnership with implementers, and in India, it's being done by Sangha.
Wow. And who are the frontline workers in the US? Who are the equivalents?
The interesting thing is the US has started its own movement for community health workers.
Oh,
So there are now community health workers operating in many states, and Massachusetts, where I live. There is a community health worker association. But the program that we're doing, which is called Empower, which is being done in India and the US, it's being done in the state of Texas. And there again, there are community health workers. Their roles are very much like the community health workers in India. They work typically in partnership with the primary health or community health centers, exactly like in India, really. So you think that the US is only top heavy.
yeah.
Actually, there are community health workers, but it is not a national program like you see in India. They don't have a national kind of a mandate as you see in India. But at the state level, there are many states that are using community health workers, and that's the group we're working with.
That's really amazing. And doctor, I wanted to ask, earlier on you had said that it was so surprising that there was a consensus on mental health. Of course, a really good surprise. But how come there is? Normally you find so much polarization when it comes to healthcare between political parties. Pushing any health reform agenda is the most painful, I think. Whether it was Obama or whether it was Clinton. So how come there's consensus on this? How come people have that level of empathy among what doesn't seem to be a very empathetic political leadership?
Yeah, it's a good question. I can only speculate, Kaveri. I mean, I'd love to actually have, ask the leaders of different parties why they supported it. But I will tell you my one experience, which was listening to the debates in the Lok Sabha when the Mental Health Care Act was being debated, and it went on for quite a few hours now, if I remember. And of course we had a dynamic health secretary then, and one must credit that these things don't happen out of thin air. You need someone holding the baby, at the top. And Shri Keshav Desiraju, who was the health secretary in the government of India at the time, was remarkable. He was truly remarkable man for his, yeah, he took a singular leadership, and it was under him so much happened, on the mental health landscape in India. But when it finally came, it's interesting. First of all, he was a UPA health secretary, and then he retired. And when the NDA came on, and so the bill could have lapsed
Yes.
completely, but it
Yeah.
didn't.
Hmm.
It was renewed, and this is a bill that began with the Congress UPA leadership. There was stiff opposition, by the way, from whom? From the psychiatric community. It's interesting. The Indian Psychiatric Society, vociferously opposed it because they felt it diluted some of the important medical issues. And I don't want to go into that conversation, but they opposed it. So you could have imagined the bill could have been killed very easily
Yeah.
because of the
Yeah.
power of the medical establishment. But actually, it was resurrected. There was bipartisan agreement. And I listened to some of the comments that people made in the House, and it was all about personal experiences. My mother, my brother, my neighbor, my friend. And you see, I think that is what made the difference, is
Yeah.
that people can see how the system has failed people close to you in a way that has no parallel with physical health problems.
Absolutely.
People will not say, oh, my mother had diabetes, she didn't get care. No, I mean, but my mother had depression, as my mother did. And then, you say, oh, actually, there was no way she could get care from. And I think that personal experience, I believe, is a very powerful driver for this kind of, motivation across the aisle to reform the mental health care system.
You talked about that, doctor. It's such a deeply personal experience for everyone. And even now, there's so much stigma or there's so much fear attached to speaking up about it. It could be your son, it could be your mother, it could be your daughter. No one really still wants to talk about it. When are we going to get over this?
It's happening slowly, Kaveri. Let me tell you, I've been in this work, 25 years. I am very reassured by the change I have seen. Okay. If you just look at this as a snapshot in time, it can be demoralizing. People are still have a lot of fear, etc. But actually, when you look at it over time, there has been a dramatic opening up of conversations about mental health. On a personal perspective, I remember 25 years ago, my family would be a little embarrassed to tell, relatives, oh,
That's
he's
Chris.
diagnosed. Today, it's they're proud of it.
Yeah.
So I do think that there is a definite change in attitudes. It takes time. Let's not forget, HIV/AIDS was such a feared and stigmatized condition, and look at the transformation. And it's interesting. We should draw to think of what transformed HIV/AIDS from a feared disease to what today is just another health
Yeah.
problem. And I think a lot of it had to do with leadership. Sujata Rao, who was the health secretary at
Yeah.
the time and headed NACO, and her fabulous leadership around the AIDS control program, legislation that was protecting the rights of people with HIV, the empowerment of vulnerable groups for HIV, sex workers,
Yeah.
sexual minorities, etc. And fourth, the availability of community-based care.
Right.
The decentralization, the availability of antiretroviral medication for free by the government. It's the only medication program that is totally free.
Right.
First level, second level, all levels. So I think one can see the ingredients of the success of India's HIV control program in all of these ways. And I think it is not difficult to imagine how these can be translated into the mental health space.
That's so wonderful. Are people thinking along these lines? Is there a sort of consolidated consensus around this?
I think there is. I think there is. Let's be clear, though, there was one big difference. HIV never had a professional body behind it.
That's
Mental health has very powerful professional bodies. And I think what we really need is to get on board our professional bodies, like the Indian Psychiatric Society.
right.
I think they must feel that they are partners in this kind of radical new world of mental health care. There was never an Indian Association of HIV/AIDS that could
Yeah.
feel, that they were being left out, or they could even be oppositional, because there is no specialty of HIV medicine in India, at least not at that time. So I think we need to find a partnership which is mutually respectful between the more public health approach to mental health care, which is what people like myself and my colleagues in India embrace, and the psychiatric approach. I think they're both needed. They both have a place in mental health care, and we should never see this as alternatives. It
Right.
has to be a continuum of care.
Right. I wonder, can India not become a global health leader with such innovations? I mean, the same innovation could be used in fighting the coronavirus. Are there not? Do we not have the seeds of becoming a global health leader in all these areas?
So, I won't say much
We've
about India
already,
as well.
sorry, I was just saying we already export, I think, the largest number of doctors to the US and to the UK anyway.
Yeah, that's true. I tell you what, let me tell you, our greatest asset, and I want to repeat what I said earlier here, is our community health workers.
Right.
Yeah, this is the single greatest human resource asset in India's healthcare system.
And
It is
not
not,
recognized enough.
well, I think the government, does recognize. I mean, without government support, it would not have happened, right? So there is recognition, but I think not enough is maybe true. I have served on the National ASHA Mentoring Group of the NHSRC now for a decade. I know that we have constant conversations about how to reduce the burden on the ASHA, how to make sure she feels, she's better compensated. I mean, she's the most important person with the least power and the least
Least,
space.
exactly.
And I think we need to equalize that. We need to be more proportionate. But let me say this. If I look at the COVID-19 response, the thing that is really going to save India has been the frontline worker. The frontline worker in our villages, who is being put at her own risk to go identify people, to help contact trace them, cases, to help support quarantine, etc. This is our greatest asset, Kaveri. The idea of the community health worker is being exported. India is not the only place where it's happened. Of course, it's happened in many other countries in Africa, for example. But it is our greatest asset. And the more we acknowledge these incredible women, the more we give them respect in the form of compensation. Respect is not just giving them a uniform.
Yeah,
I think the greater will be our healthcare system success stories.
right. What else have you learned through this other silent epidemic that has raged over the 8 months? What have your learnings been?
I think for me, when I look at the whole story, the fact that we do not have a public health authority in India has been the single most important. We don't have the equivalent, for example, like in the US of the CDC.
Right.
It doesn't exist. There are sort of certain
An
offices.
ICMR or,
So ICMR is not like that. ICMR is like the NIH. It's a
yeah,
research agency. So,
right,
you would not ask a medical research institution to guide a public health response to
right,
a infectious disease pandemic. No other country does that.
right.
We have a very peculiar situation where ICMR, whose role is to fund research. So I think ICMR plays a very important role in funding, say, a vaccine trial.
Yeah,
Uh, but to guide epidemic control, ICMR has no expertise of its
yeah,
own.
yeah,
You need a public health agency, and actually India does not have. It has no Department of Public Health. It has no equivalent of the CDC. And I think that is a very obvious, glaring issue in our country today. For example, consider the vaccine rollout plans. Every time there is an issue, you have to form a new committee.
yeah,
But that's because we don't actually have an institution.
yeah,
And I believe that is the need of the hour. I believe that is the single most important lesson. This is not the last pandemic that's going to hit us.
yeah,
And I think one thing the government, I would advocate, should be doing is setting up an equivalent of the CDC that is intersectoral. That's very important. It's not under the Ministry of Health. Because if you think about epidemic control strategies, you have to involve multiple ministries: the Home Ministry, the Ministry of Employment, of Youth Affairs, Education. So it has to be intersectoral because
right,
every sector is affected. And I think that is what we need. Something like this should maybe even be at the level of the PMO. It's something, cross-sectoral, or
right,
like the NITI Aayog, something like that. We don't have it. And
yeah,
that has been made so obvious in the way that we've generally responded to the pandemic.
right. And also, I think we've tended to shall we say, undervalue the importance of epidemiologists and place more emphasis on the non-communicable diseases for a long time. Isn't that true, Doctor?
Well, first of all, epidemiology is the foundational science of public health.
Yeah,
And you're absolutely right. Actually, when you look at many of the people who have been put in positions of decision making,
yeah,
they are clinicians.
yes,
And I think these are totally different. This goes back to our earlier conversation.
right,
Are you seeing the pandemic from a population perspective or from the perspective of the individual with COVID-19?
right,
You need actually the latter, a population perspective for
right,
prevention.
yeah,
Whereas what we've done is we've for so long talked about ventilators, plasma
yeah,
therapy, and this, that, and the other, which is important for the 0.1 or 5% of people who land up in hospital. What we have to do is to actually emphasize the large population that is asymptomatic or has not been exposed. How do we control the infection in that population? And unfortunately, that kind of skill, which is epidemiological, is much weaker in the ministries of health and so on. And I think that's why I believe a public health agency of India is so desperately needed.
right. As long as we don't treat them the way Trump treats Fauci.
Well, you know what? Fauci is a very highly regarded person in the
Yeah,
medical community in this country.
absolutely.
And actually, Fauci is an interesting because he's both a clinician and a public health leader. He's
Okay.
actually everything. He's a multi. There's very few people, you know, you can consider like Tony Fauci. But I think one thing I will say is that the US has got both an independent research organization as well as a public health organization. And I think for mental health, since we were talking about that, there's also an independent cross-sectoral mental health organization called SAMHSA. So I think these sorts of institutional structures might be really useful for India to also explore how that can be applied because India and the US share a lot in common. These are federal countries
Yeah,
where health is a state subject. These are countries in which there is enormous diversity across the country, and also there's a very fragmented healthcare system. They're very similar in that way. There's a very strong private sector in both countries, and so on. So I think there's a lot of lessons I find as I live. Split my life between India and the
yeah,
US. I find a lot of parallels, and I keep thinking of lessons I take from the US to India and vice versa.
right. That's so good. I wanted to draw your attention that we have today to the community. We've talked about the community at the individual level. What about the community institution? So far the public institutions we have for mental health have really been very grim. Is there some reform that's likely? How will they be reformed? Because the private mental health institutions are still pretty much out of reach of the common person.
Yeah, so I think we have to recognize, Kaveri, that India has a plural healthcare system, and the private sector now has a big role, particularly in outpatient care, and particularly in urban areas. So I think there's no question that the private sector has a role. I think what we must look at is regulation of both the private and the public sector, because a lot of out-of-pocket expenditure is because of unnecessary medical care. And by the way, this applies in both sectors, because a lot of public sector is not free, because many public sector places you don't have medications available. You have to often buy devices. So irrational prescription of surgery, of medicines, and medical devices is often a very important cause of out-of-pocket expenditure. So regulation and quality control is a very accountability is something that we need across both sectors. And secondly, for the large numbers of people who cannot access private care because of cost, really there is no excuse not to invest in the public healthcare system. We have got cost-effective strategies. We've demonstrated time and again that community health workers can deliver interventions for everything from autism through to depression, alcohol abuse, and psychosis. So there is no reason why the government does not have a model to actually invest in. We know how to do it. And I think, therefore, that is the need of the hour, is to invest massively in the public mental health sector, but at the base of the foundation, at the community and primary care level.
Right. And to reform the existing institutions as well.
Absolutely, I would say that's important. I think the institutions do play a role. I would, but reforming is the right word, not shutting them down. I'd
Yeah.
say reforming them to make them open institutions where there is open access to families to visit. People can go in and out. It's like a hospital.
Yeah.
It's not like a prison.
It's not
It
like a
moves from being
prison.
a prison to becoming a hospital, a genuine hospital, just like any other general medical hospital.
Yeah. Is that happening, doctor?
Yeah, it's
Any
happening in
places?
many hospitals. It again depends very much on local leadership, and those hospitals where there is a really motivated medical superintendent. It's definitely happening. It's not happening in every hospital at the same pace, but it's definitely happening. And one has to also thank the National Human Rights Commission for this, because it was the NHRC which really passed a diktat more than a decade ago, demanding an immediate reformation. And now they have to be visits. There's a visitors committee and so on. So I think the NHRC has done a really good job, and we still have some way to go. But I think in many hospitals, reform is happening.
Are you optimistic about the mental health care and the mental health architecture in India? And what do you think is the next big step that should be taken?
I'm very optimistic, Kaveri. I see, for many reasons, I see a far greater openness to have conversations about mental health. Stigma is definitely reduced dramatically. And, we've discussed that. Secondly, there is a very clear science demonstrating the effectiveness of community health worker delivered interventions for mental health problems. That's very important, by the way. 10 years ago, we did not have that science. Now we do. There is a complete acknowledgement of the science by the government in its national mental health policy, but also globally. So this idea is not just India specific, it's become a global idea. So I think these are all things that make me very much more optimistic than 10 years ago. Now what we need actually is a very specific dedication of money that goes to translating the science into action. Right now, all of the funding that, for example, Sangat receives is from private foundations and international research organizations. I would look forward to the day when organizations like Sangat are financed by the government
Right.
through its own public funds, so that it does not have to rely on private money and international money, but can actually receive local money from the government of India to do the government of India's mandate to improve access to mental health care.
Yeah. Just a last question here. Do you see the wellness centers under the Ayushman Bharat emerging as possible mental health centers?
Absolutely. I think it's the best location in the healthcare system for all health promotion
Yeah.
activities. And it's important also not to see mental health problems as isolated from other non-communicable diseases, because they often coexist: diabetes, substance use, alcohol use, heart disease, etc., and depression are examples. They often coexist. So really seeing this the health and wellness center as a place for person-centered care, where a person's health needs are holistically addressed
Right.
through a combination of medical, drug, and psychosocial interventions, is the need of the hour. It's a great opportunity, and the platforms we're building, for digital training and quality assurance are perfectly suited for that kind of provider.
Great. I hope we speak in another 6 months and we can actually talk through some of the major changes that have happened on the ground. Thank you so much, Doctor, for
Thank
joining
you very
us
much.
and for clarifying so many issues that we have on this issue, on the subject. Thank you.
Thank you, Kaveri. Bye bye.
Bye bye.